All right. See a few more people join in. We'll give everybody about 2 or 3 minutes, and then we'll all join in. All right, let's get started. Amy, if you want to turn on the pictures. Good to see everybody. I think we'll have more people joining in here as we get going. Again, I'm Mike Crosby, the founder of Veterans Prostate Cancer Awareness. It's our May 50 Vets in 50 States meeting. Thank you all for joining. We've got a great speaker that can talk to us about the TULSA procedure tonight. A couple of notes for admin notes. We've got 2 big events this month. One will be at ASCO, meeting with a lot of the sponsors and really planning for the next 6 months of the year and what our activities are going to be and how we're going to ramp things up July through December. We've also got the Society of Nuclear Medicine and Medical Imaging, which we're meeting in Vancouver this year on the 11th through the 14th to talk about really about PSMA. And I'm going to talk, I'm going to be on a panel with a few physicians from UCLA and West LA VA to talk specifically about our journey through this whole prostate specific membrane antigen or PSMA, high intensity vision or high precision imaging, and then shared decision making and how that works or how it affects everybody. So we're excited about that. And then going into July, we've got the VFW National Convention where it looks like we'll be doing some actual screening in Kansas City, so on the floor of the exhibit hall. And then a number of other things happening. You can check our events on the webpage, and we look forward to everybody being there. I will give there's a quick update on the legislative front, which is a reminder that HR 4880 and the Senate 2720 are 2 bills. It's the same bill. It's the Veterans Prostate Cancer Treatment and Research Act. They've both been introduced on the floor of both the House and the Senate. It provides some funding for the VA really to focus on some of the research issues, but it also, more importantly, looks at standardizing a lot of the policies across the VA with respect to prostate cancer treatment. Everything from what are the guidelines that the VA will be using. We know that there's a disparity between screening guidelines between NCCN, AUA, and ASCO. And what we're trying to do is to get the VA to at least standardize what theirs are across all of the VA. And we're seeing a higher incidence rate of cancer or of prostate cancer specifically in the VA. And we think it's necessary. We're pushing to get veterans categorized as a high risk population, which would push us into that category, just like African Americans and those men with hereditary disease in their family. So that's something that we're working on. We're also working to raise some funding for the military aviators funding our military aviator study around prostate cancer. We're getting quite a few people to sign up for it that are interested in participating, and now we're having to raise a little bit of money to pay for all of the assays that need to be done and the research that has to occur. So we've got grants out, proposals out. We'll be talking to some people at ASCO about it, some firms and some of the other leadership groups there. So we're excited. It looks like we're getting a lot of traction in that area. And with that, Rush, I'm going to turn it over to you and let you do the introduction. and then we'll get right into Tulsa and the Profound Medical's Tulsa procedure. So off to you, Rush.
Thank you, Mike. And I just want to start off by saying to all the veterans that are on this call, thank you for your service. And I hope you all had an awesome Memorial Day weekend with your family and friends. So I have the pleasure of working with Dr. Meng. I'm based in Dallas. Dr. Meng received his medical and doctoral degree in cell and molecular biology from NYU. He also completed his residency at NYU. He then went on to complete his fellowship in advanced urologic oncology at UT Southwestern, where he's currently an assistant professor with a huge focus on research. And a fun fact I like to share about Dr. Meng is that he has a 3D printer in his home and has some awesome gadgets that he has made with that. But I'm going to turn it over to Dr. Meng to help educate, everyone here on TULSA-PRO.
Okay, thank you, Rush, for the introduction. Thank you, everyone, for the invitation. Great to be here and happy to chat with everyone. Certainly during residency, I worked at the Manhattan VA and got to help out our veterans. And currently, I'm peripherally affiliated with the Dallas VA and have been kind of helping our veterans and the patients who get referred out, to see me in my private clinic as well. So I'm going to go ahead and share my screen. Second. Can everyone see that okay? I'm going to share it right now.
There it goes.
Okay.
That's great, Dr. Meng.
All right. So I'm here today to kind of talk to you guys a little bit about TULSA-PRO. So I started working with TULSA as a fellow here at UT Southwestern. UT Southwestern is one of the original TAC sites. I'll kind of talk a little bit about the clinical trial later on. And since October of 2020, we started rolling out our clinical program. We've treated about 60 patients to date, including 1 or 2 veterans through the Dallas VA system that have kind of made their way over to see me. And I just want to kind of give you guys a high-level overview of the TULSA procedure, how I screen men for the procedure, and how I decide which men are best suited by this procedure. And then I'll be happy to answer any questions everyone has later on. So this is my bio. You guys can look for me through the UT Southwestern website. So to talk about the TULSA procedure, so what is it? So TULSA really is called the way it is. It's a transurethral ultrasound ablation of the prostate, and basically gives us the opportunity to treat men with a variety of different kinds of prostate cancer, both men who have localized disease and men who have a little bit higher volume disease, as well as the flexibility to treat men who have enlarged prostates. And we'll kind of talk a little bit about that when we get to patient selection. TULSA-PRO is an outpatient procedure. It's done in the MRI suite, and I'll talk a little bit later about why that gives us some of the benefits compared to some of the existing technologies out there, such as HIFU or cryo. It's an outpatient procedure. Men go home the same day. They go home with a Foley catheter for about a week or so, depending on the extent of treatment. And so far, it has been, quite well received by our patients, as it kind of minimizes some of the side effects of treatment of prostate cancer while really kind of preserving the quality of life. We'll talk a little bit about the benefits and risks of the procedure, as well as who are good candidates, as well as where you can get the procedure here in the US. So TULSA, like I mentioned, is a minimally invasive procedure. What it does is it uses directional ultrasound to basically heat up the prostate tissue to about 55 degrees Celsius. This temperature basically allows tissue destruction in the prostate, and it allows it to both kill not only prostate cancer tissue, but also benign prostate tissue for men who have both BPH and prostate cancer. It's done in the MRI imaging suite. So the benefit of that is it basically allows us to really carefully monitor the temperatures within the prostate throughout the treatment. And it's used by the system to kind of dynamically adjust both the margins and the amount of energy that's delivered. This allows us to combine real-time MRI as well as a robotically driven thermal ultrasound. And I'll talk a little bit about how the procedure is performed. And here at UT Southwestern, it's done with both the radiologist and a urologist in the MRI suite. So allows us to kind of collaborate and make sure we have appropriate margins, and we're making sure we're treating the area of cancer while sparing the neurovascular bundles and the sphincter and things like that for men. So this is a diagram over here on the left of how it works. The patient is first brought into the MRI suite. They're put to sleep. We put two devices within the patient. We put a rectal cooling device that goes in the rectum. It cools the surface of the rectum to kind of prevent any damage to the rectum. We then put a urethral device within the prostate, and you can see here the device goes across the prostate into the bladder. The device has 10 different transducer elements that allow us to fire ultrasound waves basically from the transducer, and the transducer then rotates within in a circle in a 360 degrees and allows us to treat different areas of the prostate. The nice thing about the transducer, we can turn on or off elements independently, as well as how long it's firing for, which really gives us the ability to treat different parts of the prostate at the same time. So I'm going to start this video here. Please let me know if you guys have any issues seeing the video. So first we put the ultrasound device within the patient, and then we start with the diagnostic MRI. This allows us to look at the location of the tumor. We do our planning and say, this is how wide we want to treat. If I want to spare neurovascular bundles, I can spare neurovascular bundles. I can look at how anterior or posterior I'm treating the lesion and how wide I want to treat the prostate. So here you can see the device is making a 360-degree sweep throughout the prostate, and we can monitor. This view is kind of the monitoring view of how much energy we're delivering to the prostate. And is a really nice representation compared to some of the other technologies where you're going by ultrasound. If you're forming an ice ball, sometimes it's difficult to see the margins of the prostate. With HIFU, which is a different way of delivering ultrasound energy, sometimes your image becomes more and more difficult to see as the temperature, as the prostate heats up. So this kind of bypasses some of those issues. So I'm going to go to the next slide. So what are the benefits and risks of the procedure? So this is from the TACT trial data, which was a multi-center trial comparing whole gland ablation. This trial, every man had intermediate risk prostate cancer. There's a small group that had low risk prostate cancer. These patients all underwent whole gland ablation with one sweep throughout the prostate. Majority of patients, almost every patient went home the same day as an outpatient procedure. And most importantly, there was no rectal injury, urethral incontinence, or urinary incontinence. The reason I bring this up is compared to some of the other technologies, there's been reports of kind of rectal injuries with cryo, HIFU. Although these rates are low, these can be quite difficult to manage if it occurs. We have not seen this yet with TULSA, although I do have to make the caveat that it is still a relatively newer procedure. In terms of risks, I tell patients that for the majority of patients, I can preserve their erectile function if they have good erectile function coming in, though there is certainly a decrease in erectile function in certain patients. Here we see about a 24% decrease, so 24% of new erectile dysfunction. The majority of these patients are able to be rescued with medications. We do see a small rate of urethral strictures just from a rigid device and energy that sometimes requires additional methods or additional surgeries to manage. Here's an overview of the procedure. The patient comes in, they get prepped kind of 2 days before. They are in clear liquids. They get an enema the night before, enema the morning of. Once they come in, they go to sleep, and then we bring them into the MRI room. They get prepped. We put the devices in. We get an MRI on the table, so we get the most kind of real-time imaging of what's going on within the patient's prostate, and that we use for our planning images to establish how wide our margins are for the treatment. From there, once we establish our treatment, the computer sort of takes over and starts planning out and delivering the energy. With us monitoring, we can kind of see exactly how much energy is being delivered, the temperatures within the prostate. If it's going outside of where we want to treat, or if we want to adjust our margins to go a little bit further around the cancer, we can pause, redraw our boundaries, and then restart the treatment. At the end of the treatment, generally the treatment takes about an hour or so. We then get a contrast enhanced MRI to see the area of tissue that's being devascularized, to kind of show us if there's any areas that we may be potentially under treating. And so far, most of these patients have, we've been able to reach exactly what we've been setting out to do at the beginning of the treatment. In terms of what to expect after the procedure, most patients will come in when I meet with them. We'll kind of discuss, what they'll get. So I usually give them a week of antibiotics. I give them a month of medications to help them urinate. So whether that's Rapaflow or Flomax, or I continue them on their existing medications for their prostate. Afterwards, the follow-up, patients get seen at 1 month, 3 months, 6 months, 9 months, and 12 months. They get just PSA blood tests during those visits. At 12 months, I get an MRI and a biopsy for every patient, regardless of what their MRI looks like, to make sure we're not missing any residual cancer, either at the margin or somewhere else within the prostate. And if that's all negative, then they just follow up with MRIs every year and PSAs every 6 months, essentially my active surveillance protocol. The catheter usually stays in anywhere from 7 to 14 days, depending on the duration and the extent of treatment. If I treat a huge volume, if I'm treating a man with both cancer and BPH, and I'm treating a good majority of his prostate, he gets more swelling, and so I'll tend to leave the catheter in longer to allow the swelling to decrease so he can urinate when I remove the catheter. And most patients bounce back, they go home the same day. Within a few days after the procedure, they're back to kind of normal life. And then once the catheter comes out, they do have some urgency frequency related to just the inflammation from the treatment. By the time I see them at 1 month, most patients are getting back to normal kind of baseline quality of life. And by the time at 3 months, everyone is pretty much back to normal. Here's some testimonials. I won't read them to you out loud, but you guys can kind of see them. Majority of patients are quite happy with TULSA-PRO. A lot of times I see patients who actually come to me from all over the US. I've seen patients from as far as California, here in Dallas, or Iowa, and then within Dallas. And some patients are kind of looking at for different options. So as most of you know, for patients who get diagnosed with prostate cancer, they're doing a lot of research. They're looking at all the different treatment modalities, from surgery to radiation to all these different ablation methods, which is HIFU and cryo and laser. So a lot of patients come to me with a good amount of knowledge, and it's my job to kind of educate them what are the differences and what are the advantages of HIFU versus TULSA, or HIFU versus cryo, or some of these. I have a lot of men who've been very happy and kind of offered to talk to their fellow patients about their procedure and their experiences. So who makes a good candidate for the TULSA procedure? A few different things. One is this patient has to be able to undergo MRI. So, as long as they have pacemakers, if they have cardiac stents that are MRI compatible, or they have devices that are MRI compatible, they're eligible. But if they have sometimes a pain pump or an implantable spinal device, some of these men are not eligible for MRI. They have to be able to undergo general anesthesia. Generally, they undergo under general anesthesia for about 2 to 3 hours. So patients need to have enough cardiac and pulmonary reserve to be able to tolerate the procedure. And finally, there's some physical characteristics of the prostate tissue that we'll look at. They can't have calcifications that can block access of the beam to the periphery of the prostate or to the lesions that we're trying to treat. And also there's about a 3 centimeter maximum diameter of how far we're able to reach with their ultrasound energy. So men with certainly large prostates may sometimes need to be put on something like finasteride to shrink their prostate, or they may have to undergo a different procedure. So for men who are interested in the TULSA procedure, I direct you kind of to the TULSA-PRO website that kind of lists the different places around the country that are doing it. Here in Dallas, we do it at UT Southwestern. I know there's some additional centers around both Texas as well as around the country that are doing this procedure. You can see that a lot of these, especially for some of the clinical trial locations, are academic centers. So I'm happy to answer any questions you may have, and I understand we may be saving it for later. Is that right as well?
No, it's okay. I think I think we can answer a few questions, or we can take a few questions. I thought we were going to go into kind of the surgical side of things, what the difference was. I think Dr. Jones had to step off or something, but that's okay. Let's. this all comes, I mean, you clearly have got to be diagnosed with prostate cancer. So through the biopsy process and everything else before you're considered, you don't just go into the MRI and get your, get an image, right?
That's correct.
Okay. Is there any data yet on number of recurrence from this procedure?
Yeah, so that's a good question. So from the TAC trial, which was the clinical trial that kind of led to FDA approval, recurrences. So look, anytime the way I talk to patients, there's going to be higher rates of recurrence potentially with focal therapy, especially if you're treating a small part of the prostate. In the TAC trial, the entire prostate was treated. So we had under 20% recurrence rates, which are relatively comparable to surgery and radiation. For the men who are interested in truly preservation of their kind of erectile function, urinary function, and want only focal therapy, I'd say it's probably anywhere from 5 or 10% potential higher chance of recurrence compared to surgery or radiation. Two ways it could happen. Could be at the margins because we're trying to limit, the amount of tissue we treat. So there could be marginal recurrences, or it could be somewhere else in the prostate. Multifocal prostate cancer is a possibility, and we can see certainly recurrences outside of the treatment zone. I tell men that I put them back on active surveillance after we're done. I treat your dominant lesion, and then I follow you closely. If you have a recurrence, we know from most focal therapy trials that about 70% of men can be rescued with repeat focal before having to undergo surgery or radiation. So that's kind of what I tell my patients. We're friends for life after this procedure.
Do you, as a matter of course, after the procedure, do you prescribe things like Flomax or a Viagra or Cialis or something like that for guys for temporary or for long-term type of consumption?
Yeah, so men are, so I give them a month of Flomax or Apaflow around the procedure because they're going to be miserable in terms of swelling and having some issues urinating. Some men will continue it because they feel like it helps. I don't have the data here, but, generally about, by 6 months or so, actually the third half of men actually are urinating better. Part of the reason is we're treating from the urethra to the lesion. So even if we're not meaning to ablate part of the transition zone where the BPH occurs, we are for that section of tumor that we're treating. So a lot of these men do void better. So some of them will come off the medication, but a small minority may stay on the medication for urinary, to help them urinate. In terms of, medications like Cialis or Viagra, if they, about at 1 month out, a lot of patients have significant sexual side effects just from inflammation. Not unusual. We see this with, cryo and HIFU and all these things. I may give them something, just help them with sort of penile rehab, similar to what I do after surgery with my patients. I give them Viagra, not to help them with sexual intercourse or anything, but just to keep blood flow going to the penis to try to prevent any sort of fibrosis or things like that. And I do the same with TULSA.
Okay. Do you know how many VAs are actually, are there any VAs? I think as I understood from AUA, I think it was going into Cincinnati, but do you know if Dallas or any of the other, have you heard of any VAs accepting the procedure or putting it in or being trained for it?
I think, Rush may be able to better address that for the, in terms of, I'm not certain. What I do is I see patients through, I think, the Tri-West or the program. I know our VA is offering irreversible electroporation, which is a slightly different focal technology. But I have patients who get referred to me from the VA for both radical prostatectomy as well as for TULSA.
Okay. Are there size constraints? Like if you've got a big high volume prostate, or if it's swollen to a large size, are there volumetric constraints that you can do or not? Or
yeah, so the max we can reach is about 3 centimeters from the urethra. Which is actually a relatively good size because we're treating from the urethra out. We're not treating from the rectum up. So usually HIFU, you're looking at about a 4 centimeter kind of distance, but you have to account for both the kind of the rectal wall as well as the posterior prostate. But generally, if they're above 60 or 70 cc's, we may have to kind of potentially look at where the lesion is and how far we can treat. But I've certainly treated a guy with 100 cc prostate. We treated both transition zone plus his tumor.
okay. Anybody else? I mean, Joe,
Yes.
anybody else got some questions? Ben, you want to?
This is Tony. I got a quick question for you. For a man who has had the TULSA procedure and they had a reoccurrence for one of the reasons that you stated earlier, are they a candidate for TULSA second time around, or do they need a different type of intervention?
Yeah, that's a great question. So, so based on our experience, so we've done it for about 1.5 years. I haven't had a guy reoccur yet in our series, though only about, I think 10 men have kind of crossed over that 1 year line. Depending on where they recur, I would suspect that probably the majority of them will be able to get repeat TULSA. You know, if they recur at the margins or if they recur a small lesion somewhere else, most likely they'll be able to get another repeat ablation with TULSA. If you know their cancer comes back, it's more extensive than we think, it's higher grade than we think, that I feel comfortable reablating them. I think at that point I would either recommend surgery or radiation. I certainly don't think we're burning any bridges in terms of subsequent therapy, though we may find that surgery may be slightly more challenging, but I think definitely not as hard as after radiation.
I have a quick question for you, doctor. And I'm not an expert in the field by any extent, but I'm wondering, is this procedure, Bing's laughing, I can see that. Is this procedure just for initial treatment, or can someone who's been involved in treatment for some period of time, getting radiation or those kinds of things, can they still be candidates? Can this, you know, intervene, if you will, in their course of treatment?
Yeah, so I kind of use it in 3 different settings. So the primary setting, newly diagnosed prostate cancer, most straightforward, right? Intermediate risk prostate cancer, I have a lesion, we can move forward with treatment. I see men who are in active surveillance who've had their disease, they've been watching their disease for a few years. Now they either have progression of disease or they're just sick of, you know, being monitored. Then I'll say, look, we can go ahead and treat your cancer and then put you back on surveillance, but maybe you don't need the same frequency of biopsies or something like that. And then the final setting we've been doing more frequently now, but it's still, you know, I think we've done less than 5 patients, is the men who have had radiation who then recur with prostate cancer, because that's a much more difficult population to treat, because it's a lot harder to get adjuvant, you know, repeat radiation. Surgery in those guys are, you know, a really miserable affair at times. And this is actually the guys that we've treated who've had CyberKnife or who've had radiation have done quite well. And I've been surprised that they've done well, no issues of urinary incontinence. Still waiting on some of the long-term data on some of those patients to make sure we're truly curing them. But for those guys who have radiation recurrent prostate cancer, I get a PSMA PET scan to work them up. I have them see radiation oncology, and then we kind of plan if they're, you know, eligible for TULSA. They have to, you know, if they have radiation seeds, or if they have gold seeds, and they can't be within a area where we're trying to treat. But so those guys actually have been quite, you know, I've been pleased with how well those guys have done.
Okay, thanks.
A question for Profound in general. Is there a CPT code for the procedure, and is it reimbursed by Medicare yet, or is it are the insurance companies reimbursing for the procedure?
Hey, Mike, this is Mike Mydra with Profound Medical. I think maybe I'm going to take that one if I could. I'm Vice President of Global Market Access and Reimbursement for Profound, just to disclose that. A couple of answers to your questions. One is, in terms of CPT code, there is an existing C code, which actually is being used by Medicare, and it is being reimbursed by all the Medicare contractors. Having said that, we're working with a number of professional societies to try and get a series of new Category 1 CPT codes. We're hoping that we'll be successful in probably the January 2024 timeframe. Having said that, the reality is people are using, as I said, the C code and other codes, and they are getting reimbursed. So the short answer to your question is, yes, Medicare is typically reimbursing, and we are moving full steam ahead to try and get a series of new CPT codes.
Okay, yeah, thanks. I mean, that's and so Dr. Meng, I take it that if you've done this with patients that have been outsourced from or been referred out from the VA, so then it's fallen under the community care network. So that's a big issue. I mean, they won't see you, or they won't refer you if it's not Medicare approved or Medicare reimbursed at that same rate. So I mean, that's a great great thing that, I mean, that's what we're all concerned about, is how do veterans that are inside the VA, how do they ask for, I mean, we know how they ask for it. You just say, hey, I want to do a TULSA procedure. And then you got to make sure that there's a facility on the outside that is actually contracted under the community care network. And that's kind of our job, is to help find those facilities that want to be contracted and get them signed up. So that's why we do all this. I mean, that's why you're educating us, so we can help find those, right, the urology clinics, and work with Profound to try to identify the guys that have it already, and then focus on the VAs close to them to get them, make sure that they're all in the system and contracted correctly.
Yeah, so for all the patients with Medicare that we've treated, I don't think we've had any issues with coverage. The private insurances, I think, has been a little bit more hit or miss, but we've actually had some decent coverage from Blue Cross Blue Shield, from Aetna, United. So for younger men who are able to get it. So that's been a pleasant surprise for us.
Okay. I'll open up again. Any questions from the crowd? Everybody's on mute. I can see everybody on mute. If you got any questions, raise your hand or throw them out there.
Yes, doctor. My name is Donald Williamson. How do I get in contact with you? I lead a support group, and might want to talk to my support group about this new procedure.
Mm-hmm.
How do I get your information to contact you later?
Yeah, what I'll do is I'll just put it in the chat. I'll put my email in the chat, and you feel free to kind of reach out to me over email.
Okay, thank you.
And Don, we can get it to you as well. I mean, let us know. We'll get you in touch with the guys. Okay.
Okay, thank you.
Yeah. Anybody else? Questions? If not, I'm going to, and if something comes up, we can always go back. But I'm going to turn it over. I'm going to ask Dr. Jones to come on. Dr. Jeff Jones. He's the head urologist at Houston DeBakey. Also works out of the Baylor Hospital, Baylor Center there in Houston, Texas. And Jeff, we were going to ask about sort of the topic of the day was around prostatectomy, and why. Obviously, it's been the treatment du jour. I mean, it's been the most most prolific treatment out there. And why is it, or how does a patient choose, or how does a physician choose to give a patient a prostatectomy, or what are the limitations around that patient and having a surgery?
Okay, well, thanks, Bing. I appreciate the intro, and glad to talk with your group. I would say that when it comes to deciding on the most appropriate therapy for a man that has prostate cancer, it's going to depend on several factors. One is patient factors that have to do with his general health, his age, his ability to recover, his comorbidities, etc. And then has to do also with the tumor, how large it is, what grade it is, and Gleason grade group, and so how aggressive it is, and whether or not it's localized to the prostate or it's spread beyond the prostate. So all of these are factors in determining appropriateness for surgery, and what type of surgery should be done for that particular individual. And as Dr. Meng had already talked about, if a man has a prostate cancer that's worthy of intervening, in other words, it's not a low grade, not a Gleason grade group 1, but something that is deserving of therapy, and it's of adequate volume to justify the intervention, focal therapy does play a role. It's just that it's not as well proven compared to the other modalities, which are surgery and radiation. So the modalities that have the longest track record and the most data to support their use are surgery to remove the entire prostate, or radiotherapy of the prostate and the prostatic bed. So those are the tried and true methods. Those are the ones that have the most data over decades of experience in utilization and in follow-up. And so those tend to be the ones that are most commonly recommended by urologic oncologist and radiation oncologist because we have the most information about their effectiveness and about what the side effects are. But that's some of the downside is that when you have a radical prostatectomy, you had the best chance of a cure of any other therapeutic modality. However, you're also more likely to have some side effects because it is a radical operation. The younger you are and the earlier you get the cancer, the less likely you are to have side effects. The older you are, the more aggressive the cancer, more extensive it is, the more likely you're going to have side effects. So if the cancer is extending outside the prostate and invading the neurovascular bundles, you might have to remove the neurovascular bundle, which will make you more likely to have erectile dysfunction, for example. Or if it involves the bladder neck and you have to resect part of the bladder neck or part of the urethra because it's at the apex, then you're more likely to have some problems with continence. So those are the main issues: is the age of the patient, the comorbidities, no diabetes, no vascular disease, and a smaller tumor that's confined to the prostate, is organ confined, as we say. That patient is more likely to get a good result from a radical prostatectomy than somebody that's got extensive disease or has a lot of comorbidities.
Yeah.
Many times with extensive disease or with comorbidities, instead of surgery, we'll recommend radiotherapy. And radiotherapy can be done with external beam. It could be IMRT, it could be proton therapy, or it could be a combination of brachytherapy with the placement of radioactive seeds and external beam treatment. So depends on the amount of disease, its localization, and how extensive it is relative to the organ as to what type of radiotherapy can be offered. But you can even radiate the entire pelvis if necessary, which includes the lymph nodes if you're suspicious about lymph node involvement. The problem is with the higher dose of radiotherapy, you're also more likely to have side effects. And that can include things like incontinence and erectile dysfunction that happen later in the course. If you have surgery and you had those issues, you have them right away and they tend to get better. Radiation, you don't have them right away, but they tend to get worse over time. The other thing you can have is radiation cystitis, which causes the bladder to bleed, and you can get hemorrhagic complications, sometimes even clot retention from the blood that comes from the bladder as a result of the radiation therapy. So there's a number of side effects to both of those tried and true modalities. That's why we're trying to develop more focal treatments, if possible, to leave the prostate intact, to reduce the side effects of erectile dysfunction and incontinence, as well as to still control the cancer. And you have to use very early cancers. I mean, you have to have a very early cancer to get an effective focal therapy. If you have an extensive cancer that's already spread to the seminal vesicles or outside the prostate, then focal therapy is less likely to be effective. But if you can find it early, it's a small lesion, it's justifiable to treat. In other words, it's not active surveillance, then the focal therapies play a role. And Dr. Meng has already talked about the TULSA, and the other option that he mentioned that we have here in Houston is the HIFU, the high intensity focused ultrasound, and that can be done, as Dr. Meng mentioned, on a gland as high as 4 centimeters from the rectal wall. Bigger than that, we can't get effective therapy. Now, sometimes you don't have to treat the entire gland. If the tumor is in the peripheral zone, even though you might have a big gland, you can just focally treat the tumor and not necessarily have to worry about that size constraint. It depends on the location of the tumor in the prostate as to what you can reach with the HIFU. So we've treated men that have had big glands, 75, 80 gram glands, but had tumors in the peripheral zone that were very close to the rectal wall, and we could treat them very effectively with HIFU because we're not trying to treat the entire gland.
Hey, Jeff, on that procedure, when you're just treating the tumor that's inside the prostate, is there any data or what is the recurrence percentage or statistics about recurrence on just the partial treatment, not the whole gland treatment?
Well, it depends on whether you're talking about in-field recurrence or out-of-field recurrence. So what did I mean by that? In-field is the area that was treated by the modality, right? So doesn't matter if you're using the irreversible electroporation, a laser, a high intensity focused ultrasound, cryotherapy. These are all potential focal treatment modalities, right? So each one of those has a defined in-field recurrence rate. And with HIFU, it's about 15 or 20% will recur in field, which means it wasn't an adequate therapy to start with. And you can retreat the same lesion again with HIFU or with another modality, whether it be laser or cryo. So you're not restricted in retreating that lesion if you have an in-field recurrence. Now, the key thing with focal treatment is to have a really good sampling of the gland, because it's possible you have another cancer. Your prostate cancer is often multifocal. And so if you have another cancer develop or a cancer progress outside of your original treatment field, that's an out of field recurrence.
Yeah.
And we're it's not uncommon to see that because as we know that it's a kind of a field lesion, and so multiple areas of the prostate can be involved, and that's why many individuals like myself, when I'm treating a veteran that has prostate cancer, I'll often treat the primary lesion with a good margin around it, and then I'll go overhead and treat the peripheral zone of the contralateral side. I won't treat the whole prostate, but I'll treat the area that's most likely to have some subclinical cancer on the contralateral side, so we don't leave the high probability areas untreated. And I think that's reduced our recurrence rate from what's reported in the literature. And that rate varies anywhere from about 10% all the way up to 50% of out of field recurrence, depending on how well the gland was sampled and use the MRI to determine the presence of coexisting disease.
Question about the sampling, and that for both of you physicians that are doing the wonderful sampling. Are you, is there a move to switch to more of the perineal type prostate biopsies, or are you still doing just the standard truss and going that way?
Well, I would say in general across the VA, most of the docs are still doing the transrectal approach because they have equipment existing to allow that to happen. But I'd say that we've all heard the discussions about the advantages of the perineal approach in terms of reducing the infection risk. So if getting the right equipment, and we've ordered some equipment here at our VA as an example, so we're just waiting for it to arrive. As soon as we get it, we're going to start doing perineal biopsies. So it's a combination of having the right ultrasound unit with the right probe, including a sagittal biopsy plane probe, and having a means to guide the needle into the correct position. So you need a perineal biopsy guide.
Yeah, and Dr. Meng, what are you using in your practice?
So I'm using a kind of a combination. So we have MRI ultrasound fusion here in the office. So that's with the Urinav platform here. I also will take men to the OR for transperineal biopsy. I'm trying to get us MRI ultrasound fusion transperineal biopsy technology, probably from, I'm going to try something from Koalis to allow us to do both transperineal fusion, because right now when I take men to the OR for transperineal, I'm just kind of doing a template almost mapping of their prostate. And then for the really challenging cases, the men who've had prior negative biopsies or have a very small lesion, you know, a few millimeters where I'm worried about hitting it with fusion, we have IMBOR, so they get sampled in the MRI machine, and our radiology group has been really good about that. They've done about 800 over the last 5 years. So for if it's a small lesion, I'll preferentially send them from IMBOR. If it's a large lesion, which I'm pretty confident will hit, I'll do fusion.
Okay.
Yeah, and Mike, Dr. Meng mentioned the using the perineal approach for the MRI guided biopsies. There is new software that Urinav has developed. It's 4.0, and it will allow that capability with certain ultrasound units and certain ultrasound probes. So you have to have a combination of the right ultrasound unit, the right probe, and the right software to allow that to happen with the urinav.
Yeah.
System.
Yeah, I'll make I'll do my paid advertisement. The one sponsor over here, this Perineal Logic, these guys over here, they make same kind of thing, and it was introduced at AUA this year and had a huge uptake. So I'll make sure that everybody gets some information about the Perineal Logic thing there, and we'll probably even get you a discount if you guys want to buy one. So anyway, that's my paid advertisement for today, right?
Yeah, the nice thing about the perineologic template is that it allows you to just numb up 2 areas on the perineum and then do all the biopsies of the entire gland through those 2 locations. It's kind of central on the left, central on the right, and you can reach anterior, posterior, apex, base, all through that same area. So you're not having to use a grid like the old style perineal biopsy approach. So that's kind of the neat feature that they provide with the Perineal Logic.
Yeah, a question about we'll go back to prostatectomies. Are we still doing, or are you still doing open radical prostatectomies inside the VA? Or have you heard that guys are doing them? Or
yeah, they're definitely still being done. Okay. It's rare for us to do it. We occasionally will do one on a patient with particular anatomical challenges prior surgery. We're just now getting an SP robot to allow us to do a extraperitoneal approach easily. It's kind of hard to do the extraperitoneal approach with the XI, but with the SP it should be much easier. And so that's the hope, is to be able to offer robotic prostatectomy in those men that have hostile abdomens from prior intra-abdominal surgery, because we go transperitoneal with the XI or the SI to do the prostatectomy. So having preserving the ability to do the extraperitoneal, but there are a lot of places that don't have a SP robot, and for those that need an extraperitoneal approach or a perineal approach to their prostatectomy, you can do those with the open technique if need be. And every urologist should know how to convert to open, just in case they would have a problem and they would need to do it that way. But I would say the vast majority of the prostatectomies done within the VA at the academic medical centers are done robotically, and most likely with an XI.
Okay. I see Dr. Meng shaking his head, agreeing with that's I think pretty common across the VA. And the guys that we've known have all, I think, I haven't met anybody that's had an open. I talked to a lot of guys. I've had a lot of guys that have had the robotics, and I think fared fairly well. But Dr. Meng?
Yeah, I agree. I mean, the majority of times. So I think we do, between the different providers, probably 1,000 prostates a year here at UT Southwestern. I think maybe 1 out of those is, done as an open procedure. But yeah, the vast majority of these, I think most trainees coming out are much more comfortable doing it robotically versus doing it open. And we still, when we do open neobladders or open cystectomies, we'll similar approach. But yeah, the training is not nearly as much as we used to be.
That's great. Would you doctors give me an estimate about how many, if you looked at all the prostates in a year that are being reported or being diagnosed, how many do you think are being treated, focally now, like a percentage? I know it's a guess, but focally versus surgically versus, say radiation wise.
Are you talking about veterans, Bing, or are you talking about men in general?
Yeah, no, in the VA, I would say in the VA, Jeff.
Because it's a little bit skewed by the age distribution of the population, and your older men you'll have more of them that are going on that are diagnosed in their older age of going on active surveillance or getting radiation, just because they're more likely to have some cardiac disease or other factors that would not make them good surgical candidates. If you're dealing with the younger men, and I would say that we're a little skewed in the VA. We see a little bit more men diagnosed at an older age, unfortunately, because not everybody comes in and gets their prostate biopsy in a timely way. So I would say we're probably about 50-50 radiation versus surgery. We try to offer surgery to any man that is that's a good surgical candidate that wants to have intervention for their prostate cancer. We think it's the best therapeutic modality, but I would say at least 5 or 10% of the men want intervention but don't want a prostatectomy, and they're opting for HIFU as an option. We don't have TULSA here at this time, but we do have some laser interstitial therapy available for the extra prostatic disease, and we typically use HIFU or cryo for recurrent disease after radiotherapy. So if somebody's already had radiotherapy and they're getting salvage treatment, we'll offer them focal therapy.
Yeah, Dr. Meng, is TULSA do you use general anesthesia for the TULSA procedure?
Yeah, so generally they're under a general anesthesia for about 2 to 3 hours. It's important that they don't move at all because any sort of motion throws off the MR thermometry. So they're fully kind of paralyzed for the whole procedure.
So those patients sort of fall in the same category as a prostatectomy, as a radical prostatectomy, right? I mean, it's the same physical kind of considerations.
Yeah. In addition to that, you also have to consider the size of the patient because they have to fit within the MRI machine, and it's not just being able to fit in there for a prostate MRI because of the additional equipment and padding. Sometimes we do have to kind of run men through the scanner to make sure they actually physically fit within the bore. But generally something in the 350-pound range is when I start to worry they may not fit.
If they're not fitting, they probably got other issues besides prostate cancer. But anyway, let's all be honest here, right? Okay. Anybody? I'll go around the horn. Anybody? Questions? Comments? Terry, I know you've got one. You're on mute.
Yeah, I do have a question for Dr. Jones. He's sitting in front of a picture wearing a flight suit in a cockpit. Would you fly?
Yeah, that picture there was taken with VMFA 112 and a Hornet. This was pre-deployment to Iraq in about 2008 or 9, I think.
Ah, cool. I flew F4s.
Yeah, a little preceding current inventory. Although I did get one F4 hop when I was in at Pensacola. There was a few F4s still there. I guess they were acting kind of an aggressor role in the day when the younger fighters were coming aboard. But that was many moons ago.
Indeed.
And that was a Marine Corps Hornet. So I don't have any flight time in Navy Hornets. I've got Eagle, Viper, and with the Air Force, but then all the Hornet time I have and Prowler time are with the Marine Corps.
Oh, so no night traps?
Well, yeah, no, we did a few coming off the Lincoln when I was there, but again, the Marines have their own tailhook inventory. So
yeah. Okay, you can stay.
Okay.
You passed the test, right, Terry? That's good.
You can be my doctor anytime.
Yeah. Well, good. Anybody else comments? Because I appreciate it. I think we're coming up on an hour. We covered a lot of issues from TULSA-PRO, and thanks to Profound Medical about putting this thing together. I think that it's a great example of the new technologies for focal treatments coming out for prostate cancer, and we encourage all of those things. And I think it behooves all of us. And I see there's about 11 of us on here that are directly involved or engaged with the VAs, that we start talking to our own urologists about it, asking them why we can't get it, or what do we need to do to get the capability inside the VA, like we do with all of the other stuff, right? It's just about asking the questions and opening up the discussion. So no, I appreciate it. Admiral Hall, you were going to say something, looks like?
Well, first of all, I just want to thank both doctors for their presentations and their service to those of us that have prostates. It makes a big difference. Also, earlier on, it was said about, or in one of the slides, men talking about prostate. And I think one of the life-saving events is to talk about men's issues. Too many men are afraid to talk about anything from their thigh bone to their belly button. Don't talk about it, don't touch it, don't look at it, don't pull it, don't stick anything in it. And also, Dr. Meng, during your presentation, I did not fold over in pain as I looked at some of those slides, but definitely we're making tremendous progress from taking out prostates with dull deer antlers to today's technology. And Bing, I thank you. And I do talk to my congressman with VA concerns, and we'll continue to bring this up. So a Laurel and hearty handshake to all involved.
Yeah, thanks, everybody. I really appreciate your time tonight. The next one, like I said, we're going to be in ASCO for 5-6 days, talking to a lot of sponsors, and I see a few of you on the call that I'm going to have meetings with, and I look forward to seeing you, Maria, and a couple of others. And we appreciate all your efforts and all that you're doing for us. And we will. The next call is end of June 28th. And I think the topic is radiotherapy in June. So Dr. Meng, you're part of the team now. If you'd like to come and listen, we do this the last Tuesday of every month. You or any of your associates in the practice there in the VA are always welcome to join and be a part of the team.
Thank you. I appreciate that.
Yep, and thank you. Thanks very much for the great talk and the great intro to TULSA. I mean, it's like I said, it's a great procedure. It's a great technology. I know it's just hitting the streets, and we think it's a wave of the future. I mean, we've got to look at these. I think still today, I mean, prostate's still the only gland that's treated wholly as when it has cancer. I mean, everything else is now going to the focal side, and yeah, we're last. We're a bunch of men. We don't talk about it, as Admiral Hall said, and we just don't talk about it. So this year is our year to make blue the new pink, and really appreciate everybody's efforts to make that happen. So thank you all.
One last thing, Bing, I hope to get a recording of this session because I'd like to get this information about TULSA out to the guys on my list. It seems like a very new technology, and the more people know about it, the better off it'll be for all of us.
Yeah, appreciate that, Terry. That's a nice feed in. Just to mention, our marketing team is putting all of the calls or all of these on our website. You can go to the 50 Vets site on our website, and they will all be this call and the briefings will all be available and recorded. And you can pull those off if you want to review them, send them around to friends, send a link to people. But yeah, they're all available. And we really appreciate that, spreading the news around, spreading the word around. So if you got any questions, your doctors want to see it, all of you guys that go into the VAs, you can give them the link. It's just the website, and go to the 50 Vets page, and they'll be listed right there. So you can refer to those anytime.
Great.
Yeah, thanks very much, Terry. Okay, I think that's about it. One more time around the horn. I don't see anybody. So I appreciate everybody's time this evening. Have a great night. And here we are. Welcome to June. Year's almost halfway done.
Thanks, everybody. Really appreciate it. Thank you all for your service. Take care.
See you guys.
Thanks, Tony. Well, good evening.